And just say good evening, welcome. Thank you, Dr. Swanson, for being here. He is going to talk on knee injuries and skiers and snowboarders, prevention, and what can be done if you do have a knee injury. I just want to remind the folks that are on the call that if you'd like to ask a question, you can do so either through the Q&A box at the bottom or the chat box, and I will help ask those questions at the end of the presentation. But in the meantime, I'm going to pass it off to Dr. Swanson. Thanks so much for being here.
All right. First off, hopefully everybody can hear me. So can you hear me? I guess, Natasha.
I can hear you, and if anyone wants to let us know in the chat box if they can hear as well, I feel good that we can hear you. Yes.
Okay. Sounds good. First of all, I want to thank Natasha for setting this all up. I think these are important talks, and it's good to get that community outreach, and a lot of effort goes on behind the scenes. So thank you, Natasha, for doing all this and getting this set up. And my talk tonight is knee injuries. It's one of the most common things that we see in winter sports, skiers and snowboarders, but other injuries as well. And it's kind of appropriate today since we had a nice, snowstorm last night that brought in a few inches. So that's always good. In the orthopedic world, we call that white gold. And so on we go here. So a little bit of background just about myself. I think most people know this by now. I've been here about 12 years now. But I did grow up in Lake Tahoe. I was a South Tahoe graduate, so go Vikings. I then did college and medical school in Texas, where I did the Health Profession Scholarship Program in medical school, which paid for my medical school. And then I joined, after my residency in San Francisco, I joined active duty with the military, with the Army Medical Corps. And I was stationed in Fort Stewart, Georgia, which is over by Savannah, Georgia, for 4 years almost, and spent a little time in Afghanistan. I am board certified both in orthopedic surgery and then a subspecialty certification in sports medicine. I did do the Lake Tahoe Sports Medicine Fellowship here back in 2007. I'm one of the ski team docs, and there's a few of us up here that are. And then I also do the team physician for a Douglas High School, which my basketball coach would be disappointed, but that's okay. So overview, we're going to talk a little bit about epidemiology of these injuries, some basic anatomy, mechanism of injuries, how we diagnose these injuries, and then the different treatments, anywhere ranging from, just physical therapy and rehab, all the way to surgical types of treatments. And then, of course, the important thing is maybe how we can prevent these type of injuries. So, interestingly, since they really started keeping statistics on ski and snowboarding, especially ski injuries, the overall rate of actual injuries has decreased, and that's just because of advancements of technology, and I think people's awareness of injuries and doing the preseason preparations and things that need to be done to try to decrease those risks. And if you look at, if you break it down into ski days, on average, it's 1 injury per 333 ski days. So basically 1 injury, per 1 year of skiing. The biggest things that they used to see back in the 70s and 60s was these, what we call boot top fractures or ankle tibia type of fractures. And that was just because of the way the bindings and things were. With the advancement of technology, even though the overall rates of injury has actually decreased, we've actually seen this dramatic increase in knee injuries. And we'll get into that about with the binding and the binding release and all that. So as you can see here, the technology has advanced pretty dramatically. These were, skis or examples of skis that were used back in the 1800s. And the ones that I remember when I was growing up in the 70s and 80s were the bindings that had the straps around them. And those are actually the worst type of bindings that you could have. If the ski did release, the ski didn't fall away, and you'd end up with some pretty severe cuts and lacerations because the ski would bang into you or drag against your leg. But now with the new bindings, where there's release technology and there's no straps, we have seen a decrease in the amount of fractures, but we've seen an increase again in knee and soft tissue type of injuries. And we'll go into the mechanisms on that. So 20 to 35% of all ski injuries will involve the knee nowadays. The majority of those injuries really are not severe injuries. And the most common ligament that's injured is the medial collateral ligament, which is the MCL. And then second is the ACL. And again, that severity of injury ranges anywhere from a strain, which is where the fibers are stretched and not completely torn, versus a complete tear. But the majority of people will have a combined injury of not just a ligament injury, but maybe a cartilage injury as well. And as you know, and as it shows, 45% of injuries of the ACL, you also get a meniscal injury. And people think it's maybe the medial meniscus, and we'll get into a little bit of the anatomy, but it's actually the most common meniscus injury associated with an ACL injury is actually the lateral meniscus. And that's just because of the way the knee pivots when you get these injuries. And interestingly, women are have a 3 times higher rate of ACL injuries, not just in skiing, but in general overall. And that's just because of the anatomy of the female. It has to come down to one, when we'll go into the anatomy, show the diagram, the notch is more narrow, so it can impinge against the ACL. It also is because women obviously have estrogen, and estrogen actually can cause laxity in those ligaments and predisposing it to tearing. And then just the alignment of the lower extremity for women, they're more in what we call genu valgum or knock-kneed. And so that puts a bigger valgus force across that knee, which predisposes to injury. And not surprising, the non-dominant leg is more at risk, and that's just because the muscle bulk or the muscle strength around that knee is less than your dominant leg. And if you want to know what is your dominant leg, just don't think about it and try to take a run and jump off one leg, and that's your dominant leg. Or kicking a soccer ball. Those are the kind of examples you can kind of figure out. So we do see injuries in snowboarders as well. And really, it's not as many lower extremity injuries. It's more of the upper extremities that we see in snowboarders, and typically wrist and shoulders and elbows. And wrist fractures are 3 to 4 times higher in snowboarders than they are in skiers. And that's just for the obvious reason that snowboarders are bound to their board. They don't have poles when they're going down the mountain, and so if they fall, they're usually putting their hands out, and that's why they're at risk. And certainly, wearing wrist guards or wrist braces can decrease that risk of injury. Knee injuries are again less common, and certainly when they do happen, they're less severe. The ones that we see where there are higher risk of injuries in the knee with snowboarders are the ones that are in beginners and the hard shell type of boots. So really ski equipment, like I said, it's come a long way, especially with the bindings. And the majority of knee injuries that we see really has to do with associated with the bindings, whether they release late or they don't release at all, and that can cause a problem. And the majority of skiers that we see, especially people that are coming from out of town or recreational skiers, really don't have any idea of what their binding should be set at. And the majority of people will overestimate their skier level. And so their binding will be adjusted to a higher setting, making it difficult for it to release. And so as we see, beginners are 6 times more likely to sustain a lower extremity injury. And this is because of the fact that their bindings are set too high and the ski does not release, causing a torque on that knee. The other thing is with the newer ski boots, they have a built-in flex or forward lean. And what that does is that predisposes putting stress on your knee and an anterior force across that knee. So you're already at risk or there's already a small amount of force going across that ACL. And then with the newer skis, there's all different kinds of skis now that we have, but the shape skis, when they came out in the 90s, they're designed for having a higher or quicker turning characteristic but with a shorter length. And so it allows you to carve at a faster rate and torque. And that, again, predisposes putting a valgus stress or force across that knee. The DIN setting is obviously the most important thing, and I'm not going to even try to pronounce what this is. It's obviously German, and it's a way to measure, and it's based off weight, height, skier type, boot length, and age. And there's a setting for both the front part of the binding and the back part of the binding. And I'll show on the next, I think the next slide, that kind of shows what that is. But again, in general, the beginner skiers want to have a lower setting. They want that ski to pop off because they're at, they're falling more, they're at risk more. And with the more advanced skiers, it's opposite. They want the binding set at a higher number so that their binding doesn't release in steep scenarios or more difficult terrain. They want that ski to be able to stay on at higher forces because they're going faster, they're turning harder, they're putting more force across that ski. And so if we look here, this is the modern ski binding. We have the toe housing, and then we have the heel cup. And there is a DIN setting here on this heel cup, and this allows for, setting for the boot to be, released in a forward direction when it's popping up and out. And while when you have it at this toe housing where you're setting the DIN or the binding, it's more for a twisting or rotational force, either rotating this way or rotating that way to allow that ski to allow that boot to disengage from the ski. And this just kind of shows you the different modern binding release mechanisms. So we have a twisting where it's more in the toe going either way. And then, of course, we have the forward release, and that's for the back where the heel cup setting is. And, these are, even, knowing even just the basic information on this, I mean, these are your settings really. I think it's extremely important to take, anytime in the preseason, or certainly at least before you get out on the slopes, to have your bindings checked. I mean, I think this is one, if you really want to say, I'm going to do one thing to prevent or decrease my risk of injury, it's really taking your skis or your board in and getting the bindings adjusted appropriately based on your skill level, your skier or snowboarding level, but also based on, height, weight, what your, athletic ability is at that time. And it changes year to year. So I think it's something that's very important that's overlooked. And I can't tell you how many times where I go to the ER and someone says, yeah, my binding didn't release. And you start drilling down into it. And it's just that they didn't get it checked, or they overestimated what kind of skier level they were. And, skier types, we basically classify them into 3 different types. Type 1, it doesn't mean you have to be a beginner. It doesn't mean a beginner skier. It really means someone that's conservative, someone that doesn't want to ski on the steeps or an uneven terrain or unpredictable terrain, and they want their binding set at a lower level so that they do release and they decrease that risk of injury. The moderate skier is someone that, they want to go fast, they want to be on a little bit steeper terrain, but when it gets to the steeper stuff, they try to avoid that, and so they want to get their binding set more in the middle. And then you have the type 3s, and these are the skiers that are extremely aggressive. They're going on steep terrain where the risk of falling or the risk of your binding releasing can be more catastrophic than if it doesn't. And so these are the skiers that you're seeing skiing on very advanced terrain. And again, the risk of the binding popping out is worse than if it doesn't. So it really is important to know what your ski level is, and then being able to communicate that to either whoever's setting your bindings, or if you set your bindings, to be able to have that in mind. And then again, there's different mechanisms of injury. It's the classic injury, the boot-induced injury, and the phantom injury that we see. And the classic injury, what we see is a valgus external rotation force. And what happens is the skier loses balance, leans forward, and then that inside ski edge catches and twists the knee or twist the leg externally. And you can see if someone's a beginner, this would be when you start to get that force, that external rotation force, that's when you want that ski to release off the boot. And if it's set too high, it can't, and that causes a huge torque up here in this area, and that force is amplified coming from here all the way up to the knee. And so that's why it's important to have that binding set at an appropriate level. And then the boot-induced one is where someone takes a big bump or a flat landing on a jump, the tail of the ski hits first, and then the boot is forced forward, and the tip is forced down, and that boot will release forward. And if the ski doesn't release, it can put a significant strain on that ACL and causes that forward momentum to kind of occur through the knee. And again, that can cause that tearing or rupture of the ligament, especially the ACL. And then we have the phantom foot, where the person's in the backseat position. With these newer kind of shaped skis, the tail can carve into the snow, and the ski will actually accelerate forward, as you see here. And then you get a significant amount of anterior translation, which means the tibia, the shin bone, will move forward. And what happens then is you have a natural reaction of the quadricep muscles, which is that big muscle in your thigh, to contract, and that causes deceleration of that force going forward. But at the same time, it puts all the strain or force across the ACL. So don't be this guy. So typically, what we hear when we see patients, and again, this may be more towards skier, but it's not just skiers, but it's, anybody playing sports, playing basketball, any type of pivoting sport, things that we're looking for in the history when someone's telling us when they're injured is, did you feel a pop or heard a pop? And typically patients will, I'd say about 70 to 80% of the time, they'll feel a pop or they'll hear a pop. If it's, and it doesn't mean it's always the ACL, but it certainly means something significant has happened in that knee. Typically they'll have swelling. Now it's interesting, if, swelling doesn't have to occur right away. It just depends on the type of injury. If it's a pretty high energy type of injury, that swelling can occur pretty much immediately. But if it's a lower energy type of injury, sometimes it takes a couple of days for the swelling to occur. And so someone will say, yeah, it didn't really swell until the next day or a couple of days later. And then, patients do have, they would go to stand up, and it's, and it's one of these things that, you fall, your ski comes off, you go to stand up, try to put your ski on, your knee just doesn't feel right. It gives out. It doesn't feel like you can hold it up. And that can be one, maybe the ligaments injury. It can also just be the fact that you're kind of in a, not really shock, but you're recovering from the immediate after effects of the injury, and your muscles are maybe not firing on all cylinders. Then we look for what we call the mechanical symptoms. And this is more for like meniscal injuries or cartilage injuries, catching or locking, like you're going through a range of motion on your knee and you feel like the knee is catching, like you can't bend it past a certain point, or it feels like it's, it's going to lock. And then of course, pain with weight bearing, impact returning. And then a lot of times patients go, I don't know, it just doesn't feel right. There's something wrong. It doesn't feel quite right. So those are kind of the catchphrases that we're looking for when we're talking with someone with a knee injury. And so this is some basic anatomy, and what this diagram is trying to show is, what I'm really trying to show on this diagram is, this is the knee joint right here. This is the front of the knee right here, and this is the back of the knee right here. And what you can see is there's a tremendous amount of muscles that are above and below the knee, but also that cross the knee joint. And those muscles really are extremely important in what we call dynamic stability and just positioning of the knee. And it's not just the muscles of the, that are around the knee that are important, but it's also these muscles. This is the hip joint right here. It's really these muscles around the hip. The hip is so important for keeping the knee or keeping the lower extremity in alignment through any type of athletic event. And these muscles are really overlooked in a lot of conditioning, or when people or working out. I mean, and I'm guilty of it just as much as anybody is. Nobody goes to work out and go, look at my short external rotators on my hip. I mean, nobody does that. But these muscles are extremely important for keeping the limb in proper position through any type of athletic event that you're trying to do. So these are things that when you go to therapy or when you are conditioning, that a trainer will maybe, focus in on, and people go, well, why did I do that? Why is that going to help me? Well, by getting these built up and getting these stronger, it basically sets up for the rest of the whole lower extremity. I mean, of course, it's important. These are your hamstrings in the back right here. And then these are your quad muscles. These are also very important, but these can't be overlooked as well. And then as we look into the knee joint itself, this is what we call an axial view. Like if we cut your knee in half and we're looking on the top, this is the tibia, the shin bone right here. And these are your two menisci. This is what we call the medial meniscus, which is a shock absorber of the knee. And this is your lateral meniscus on the outside part. And then this is your ACL starting in the front of the knee and working over to the lateral side. And this is your PCL. And what these are, these meniscus, they're really the shock absorber of the knee, and they really do basically provide significant protection of the cartilage on the tibia and then also on the femur over here. And so this is looking directly on top. And then if you look, this is looking at it from the front. So this is your femur right here, and then this is your tibia here. And then you can see the meniscus here and here are again acting as the shock absorber between these two bony structures. And what I want you to see here, this is the ACL obviously, but what again, when we talked about females at higher risk of injuries, this is the notch when we're talking about the notch. And in females, just in their anatomy, the majority of them have a much more narrowed notch. So that notch can actually impinge. And so when someone, usually when you get an ACL injury, it's a hyperextension injury. That means the knee extends or hyperextends. And if that notch is narrow, if that notch is narrow, it can impinge on that ligament. And then this is just showing there's actually two bundles to the ACL, and one's tight in flexion and one's tight in extension, and that's not quite as important. This is your MCL, the medial collateral ligament, and this is the one that's most commonly injured, and that's because the majority of injuries in skiing and snowboarding or any kind of winter activities, it's a valgus force. And when I'm saying valgus force, that means this part of the leg is being forced this way, as is this part. So when you're forcing these two this way, it puts a lot of stress on this area right there. So this is what we call a Lachman exam. This is what we're testing for, to see if someone's torn their ACL. So we'll see, hopefully the video plays. So you can see how kind of loose that is. And what's happening is I'm testing that ACL in about 30 degrees of flexion. And what I'm feeling for is a nice, what we call solid endpoint. So what you can see on that video demonstration is it's a pretty soft endpoint. You can see the tibia is just basically kind of, I'm able to put it in the position without any kind of resistance. And this is, in experienced orthopedic surgeons, this Lachman test, what we call Lachman testing, is extremely sensitive. And, in someone that has, experience, it's almost 95% sensitive and specific for an ACL injury. And, we can basically almost diagnose the ACL if we can get them relaxed enough just with this maneuver in and of itself. And so if we look, typically we'll get an MRI, and MRI is great for looking at soft tissues. Obviously we get x-rays too to make sure there's no fracture, but the MRI is the gold standard for looking at what we call soft tissue injuries. And this is looking at the knee from the side. So this is the femur from the side. This is the tibia from the side. And then as you got here, this is the kneecap or the patella. And then this is your ACL. And what we're looking at here is this nice dark structure. That's what a normal ACL should look like. And that's, now we know that ACL is intact. But if you come over here and look on this injured one, so again, this is the femur, this is the tibia, and then the kneecap or the patella. This is that ACL that's been torn. You can see it's kind of it's wavy. We say it loses its tension or its fibers. And you can see a little bit of waviness, and it even looks like it's almost kind of balled up right there. Sometimes we don't get that good of a look on the MRI, it just depends on the different machines that we use, and sometimes it's just the cut of the MRI that we get. That section of that view sometimes is not right on. But typically, like I said, by exam and by MRI, we can pretty much diagnose it 98% of the time. And then this is looking at the meniscus. This is the femur, this is the tibia. And again, this is looking at it from the side. So this is the black triangle and then the black triangle. And I'm gonna go back to the slide real quick and what we're looking at, everybody goes, well, those are weird looking. Why are they black triangles? And what's happening is I'm taking a slice of the knee through, we're basically slicing it like this. And so if you can imagine, when I'm looking at it from the side, there's the meniscus here and the meniscus here. It's not two separate meniscus, it's still the same meniscus, but we're seeing it from the side. So we're looking at it from this way, looking in this way, and we're seeing that little triangle here and there. So this is what a normal meniscus looks like. Again, it's nice black structure, and that's what it should be. And then if you look here, this is an obvious tear. So this is a meniscus here, and then this white line right there is that tear of that meniscus. So typically, initial treatment on any injury, is pretty standard, whether it's a bad ACL injury versus a fracture, or versus a strain or a sprain. It's what we call the RICE treatment. And that's where we obviously rest, and typically don't try to ski down if you've injured the knee. And I've seen that where someone will get up after they maybe have had a minor injury and they'll try to ski down, and then they'll fall again and they'll end up with a more severe injury that maybe will not have been that bad. So I think it's really important to, be self-aware, and certainly, that's what ski patrol is there for. And I think it's, the worst thing to do is maybe turn a minor injury that wasn't too bad into a more severe injury that could, that ends up requiring surgery. So obviously it's rest, and then ice, and then compression, like an ACE bandage or something around the knee to kind of keep the swelling down, and then elevation. And that's just a general rule for, for any of the, injuries. And then an anti-inflammatory is always good to help decrease that inflammation at the injured site. Isolated MCL injuries, I'm not sure why I just put that out specifically, but typically MCL injuries, they're what we call extra-articular. And everybody goes, well, why don't you operate on the MCL, and why do you always operate on the ACL? And I'm going to go back again. So what you can see here, the MCL is over here, and we call that extra-articular. And when it's extra-articular like that, that means the capsule and everything else is on the inside. And so there's no synovial fluid that comes out. So when you get an injury, this is able to form a clot very easy, and then allows that healing mechanism to take over, which means you get the clot, then you start to get the scarring, then you get the fibers that kind of grow in, and you get the healing. So an MCL injury, an isolated MCL injury, rarely, if ever, requires surgery, just because the healing is so good in this area. The problem is with the ACL is it's what we call intra-articular. It's within the joint. And so there's synovial fluid that kind of lubricates the joint. And so when you get a tear here, you can't form a clot. The synovial fluid really prevents a clot formation. And so there's no way for these fibers to really kind of bind together to scar in to kind of form a new ligament. And so that's why we end up having to typically do surgery on these ACL injuries, because it's an intra-articular structure. And that goes with the meniscus as well. And the other reason the meniscus does not heal is, if you look here on this diagram, the blood supply is very good to the outside part of the meniscus. It gets really good blood supply here. But as we get further into the inner portion in the knee, the blood supply is very poor here. And so the healing response is not good at all. And so this area, we actually label this the white zone, because there's no blood vessels at all here. And so when you get an injury, it does not heal. So bracing typically for MCL injuries, and then the recovery is anywhere between 6 to 8 weeks for recovery, depending on how much is injured. Typically it requires physical therapy to work on strengthening and motion. And then there's these things, there's more kind of advancements in, medical, intervention, which is, PRP injection, stem cells. PRP is what we call platelet-rich plasma, and that's where you draw blood out from your vein, take that blood and spin it down to extract the platelets. And the platelets are important because they stimulate a healing response. And so what you can do, and when you hear about a pro athlete goes, yeah, I strained my knee and I went to Germany to get my injection. Well, you don't have to go to Germany to get the injection, but there's a famous surgeon out there in Germany that does all the injections like on the NBA basketball players. And what they do is they inject that PRP or the platelet-rich plasma into that area of injury to try to stimulate a healing response. And then with ACL and meniscal tears, they typically usually require surgery, and full recovery after surgery is about a 6 to 12 month recovery. And that's not means you can't do things or you can't walk. It just means getting back to getting the strength back, getting the motion back. And a lot of it's coming back to getting the confidence back. One of the biggest things with people that have ACL injuries, it's not the fact that their ACL isn't healed or hasn't after surgery, but it's getting the confidence back. And because it is a devastating injury, and there's a lot of psychological factors that go into recovery. I don't know if you can read this short, it's a little bit blurry, but in case of skiing accident, it basically reassemble as indicated, and it says right leg, left arm, right arm, head. This is just a picture of the knee scope, and we're going to actually play some video. So this is a video of what a normal ACL looks like. And what you're going to see here, this is the ACL. I'm going to put my probe. And what this is showing you is a couple of things. One is this is obviously within the knee joint, but there is some laxity to the ACL normally. If you can look at that again, it's not like the ACL is this tight rubber band type of ligament. There is laxity in different positions, and it provides stability through a range of motion. And so we don't want that ACL to be tight like a rubber band, or tight like something that's unforgiving. It has to be a little bit of laxity to allow that knee to move. The knee is a very complex joint that it doesn't just move like a hinge. It moves with rotation, flexion, extension, side to side. And so there's a lot of things that have to work in coordination for it to function appropriately. And then this is looking at the,
this is probing the meniscus.
Yeah, I'm kind of talking there.
Nice
so
and clear, nice and no evidence of any injury or any kind of tears underneath. A little loose body there, soft tissue. But that's a very good looking medial compartment. Looking a little bit of softening in the cartilage, which we call grade 1, but no evidence of any specific.
So what you can see there is kind of like in that diagram. So this is the femur. This is what an absolute normal cartilage looks like. It's absolutely perfect. There's no dings, there's no divots, nothing. And that's what it should look like. And then same thing with the tibia. That's what a normal tibia cartilage looks like. So this was obviously in someone that's young, that hasn't had any significant injuries. And then what you can see here is that meniscus, and you can see how white this is. There is no blood supply coming in here. Usually when we go into a joint, you'll start to see those small little, what we call corpuscles or vessels. They get irritated when we just do even a little bit of surgery, because surgery is a little bit, it is trauma. And you can maybe make out a little bit of the red right there. You can see on the periphery of that meniscus, there's some blood supply there. But the other thing that you notice here is there's no redness on any of these structures here, cartilage. Cartilage does not have any blood supply. When you ding the cartilage, or when the cartilage gets injured, it does not have any capability of healing. It cannot heal. And that causes an imperfection on that articulation. And over time, that, even with just a small injury, over time, that can cause what we call arthritis down the road. And all arthritis is just a breakdown of cartilage. And then this is looking at I think an injured ACL.
We'll come back and get better visualization once we get our scope in there. But that's what we call an empty wall sign right there. That hole back there is where the ACL should go, and you can see it torn off.
So what this is showing is this is looking at that notch. You can kind of see here, And the ACL fiber should be coming along right like that. And you can see, we call that the empty wall. When we go in there, that it's basically empty there, and that's where the ACL should be. And you can see some of the torn fibers of that ACL right there. And then this is looking at a meniscus tear. And you can see this is a flap of that meniscus, and there is no bleeding there. There is no blood supply. I mean, if I did that on something that has a normal blood supply, there would be bleeding all over this area, but there is nothing there. So you can see, I could put a suture through there and I can make that thing look perfect, but it's not going to heal, and that's not going to do any good, unfortunately. And so what we end up doing is what we call, a menisectomy, and that's where we take out part of the meniscus. It used to be back in the 70s, they actually thought the meniscus was not it wasn't needed. And so the surgeon, or actually orthopedic surgeons, were graded on how good of a surgeon they were by how fast they can take out a whole meniscus. And they even had instrumentations and that they could use to basically rip out the whole meniscus. And they found out pretty quickly later on, about 3 or 4 years later, that all these people are starting to get arthritis, because that meniscus is basically a shock absorber of the knee. And you can see what I was doing there is chewing out that piece that wasn't fixable, but trying to keep as much as I can of the meniscus intact. And so this is afterwards, taking out that piece that was flopping around, you can see, but I tried to maintain as much as I can to still keep that shock absorber. But back in the day, like in the 70s, and again, they didn't have the technologies like MRIs or scopes, so they felt that this meniscus was not any use, so they would take the whole meniscus out. Well, what happens is a dramatic increase in force across the cartilage, and people would wear their knees out extremely fast. And this is just another example of the ACL torn. And this also shows, I was pretty excited about this, because this is a tear of the meniscus in the front. And when people say, I can't bend my knee or my knee locks, what's happening is this shows a great example of how this flap of meniscus can get incarcerated into that knee joint, blocking that motion. This just is showing an example of me drilling a hole where we're basically putting in the ACL. And just a lot of the bone elements and stuff getting into the knee, which actually, so interestingly enough, those elements, what we call marrow elements, actually help in healing. And so by doing an ACL, you actually do stimulate, and they've shown good studies that meniscus tears associated with an ACL tear actually do very well. And
there's a device that's going to catch on the outside.
This is the device that helps secure the ACL.
And here comes our graft that's prepared.
And then this is the ACL, the new ACL graft going in. You can see where the empty wall was, and now my graft is filling that wall up. And so you can see now that the new ACL is kind of in place.
And then we're going to pull on and test it.
And then we're going to set the tension. And again,
that's the new ACL.
And again,
you can see now we got to fix it on the tibial side and on the femoral side, but that's the new graft and it looks good. And again, nice positioning. Again, we try to recreate the anatomy there.
And what's going on, and that whole thing, I think I have a picture of that. So what we're showing is that we're recreating the anatomy, but we don't want to over-tension. You can actually over-tension the ACL, so we're trying to avoid that. And this is after that the ACL has been fixed.
Range of motion as we get full extension, it doesn't impinge on the front. And that's at full extension there. And then as we flex it, there's no impingement of the graft on the PCL.
And what I'm trying to show in that extension,
just want to see
what I'm trying to show when I'm throwing through a range of motion is making sure that this thing doesn't get impinged on the notch. And some people with a more narrow notch, we actually doing what we call a notch class, where we actually take a little bit of widen that notch just a little bit more so that that ACL is not at risk of injury again. So prevention, I think, is probably the most important thing that you can do, whether it's whether for the winter or for any kind of season that you're getting into. Cardio, of course, is very important, and that can be anywhere from running, it can be cycling, it can be swimming, it can be walking, hiking. All those things are good cardio. And I think having a consistent cardio program is extremely important throughout the season, not just preparing for one season, but throughout the year. Strengthening, again, and knowing what to strengthen. And again, I think, if you're looking at knees, it's not just strengthening the muscles around the knee, but it's the hip. It's everything that kind of goes along with that lower extremity. And then balance and flexibility. And that comes with, snowboarding and skiing are very dynamic sports and unpredictable dynamic sport. And so we have to be able to have good balance and have to be flexible. So stretching program, core strengthening program, all those things are important. And then of course, plyometrics, being able to position and hold a position, all that stuff is important. And I think you can get that either through, there's certainly a lot of online stuff or going through therapy. There's also, Barton has a great, sports program. It used to be, I can't remember the name of it now, but there's good training programs that you can get and use. And then, of course, any gyms, there's trainers that can show you the proper way to condition. I think during the season, properly adjusted equipment. I cannot emphasize this enough. Making sure your equipment is good every year at the beginning of the year before you go out, making sure the bindings are set, making sure your ski boots fit, making sure the skis are properly tuned. And that means if you're going to be skiing on a day when it's icy, you need to make sure you have sharp edges. On a day that has soft snow, making sure you're using the appropriate wax that doesn't allow for sticking. Warming up and doing something as simple as just walking from the car. That's a good dynamic warm up, but something to warm up and not just going out there and hitting the slopes, hard. Stretching is important, whether it's dynamic or static stretching. And then start off slow, make sure you start don't try to go do the hardest run from the very beginning. And then it's important to take breaks. I mean, skiing and snowboarding and any of these downhill sports are truly, they take a lot of energy and your muscles get fatigued pretty quick. So making sure you're taking breaks and know your limitations. I can't emphasize that enough. Know what you can do and what you can't do, and know your ski conditions or your snow conditions, knowing if it's icy, knowing if it's, soft snow or hot or warm or whatever. But I think knowing those things are important. Other thoughts, helmets, of course, I think that's a no-brainer. You should be skiing or snowboarding with a helmet. It saves lives for sure. Dress appropriately for the conditions. Hydrate. I mean, we're in the mountains, breathing hard. You lose a lot of moisture through your lungs. And so hydrating is extremely important. That doesn't mean hydrating with alcohol. That just means hydrating with water. Taking breaks, making sure you're getting proper nutrition. Avoid excessive alcohol until maybe after you're done. One of the worst injuries I saw was a guy who was down at the California bar and was drinking. He had these old 210 skis with bindings that had still the straps that go around the boot. He had gaiters on, and he looked up at the gun barrel and said, "I think I can ski that." Didn't realize that the ski conditions were terrible. It was a solid sheet of ice, and he basically took one turn in and slid all the way down, hit a tree, broke his femur. So it's one of these things that you need to know your limitations and be smart. These are just some recent cases. These are things that, you see. This is obviously a high energy fracture. This is the tibia. You can see this thing is shattered. So these can happen. And this guy developed a compartment syndrome, which means the muscles swelled up dramatically. And so we had to release the fascia to allow those muscles to expand. And then once the soft tissues calmed down, we were able to close it back up and fix this tibia. And then this is the type of thing that you see sometimes, a lot of metal to reconstruct that whole joint. And that's obviously at the severe end of injuries, but we do see those every year. And then this is someone was skiing, he ran into somebody, they fell. The other guy's ski popped off, and this is across the front of the knee, and the ski was sharp, and it came right across and cut. This is the kneecap here. This is the patella tendon, and it cut right across, a nice clean cut. The lucky thing for her was that it didn't injure the cartilage. And so we basically sutured the tendon back together and then obviously washed it out, made it clean, and then closed up the wound. So that's it. You guys can enjoy this last video. This is when I got to fly the Thunderbird. So this is the takeoff scene. This was the coolest thing I've ever done, by the way. So this was pretty fun. And then the best part about this whole thing was we actually got to fly over Tahoe. So that was pretty cool to see Tahoe from that perspective. And he didn't really tell me about what he was going to do here. He just said, hang on, right about here. All right. I think that's all I got.
Great. That was wonderful. I'll just remind the attendees on this Zoom call, if you have questions, we would love to ask them. So please enter them into the Q&A box or the chat box. And we do have one that's already come in. The question is, what is the typical time frame for someone coming off ACL surgery to get back on the snow?
That's a great question. So there's a lot of things that we kind of go through. If you just looked at just a generic, time frame, it used to be that we'd say anywhere between 6 months, but we're actually finding that it takes a little bit longer for people to get back. And, that's where good, physical therapy comes into play. And now I tell people typically 6 to 9 months to get back to skiing. And with these high, even with these higher level skiers that we see, they're really not getting back to full snow for about 9 months to a year. And it takes that long to get that strength back, especially, the quads and the hamstrings, but also, again, like the hip muscles. And then again, the other thing that we really see, there's a psychological component to it, getting the confidence in the knee. And a lot of therapists, I know at Barton, I know with the therapists I work with at Barton, about the 6 month mark, we'll do what we call a functional knee test. And that's where they go through different exercises with both legs. And then they basically grade them. And the goal is to get 90 to 95% on your injured knee compared to your non-injured knee. And when you get to that level, if you get to that 95% threshold, at that point, the therapist will really kind of advance you on your activities. But I'd say if you had to just pick a generic number, 6 to 9 months would be the time frame that I look at.
Another question about prep for surgery. Is there an ideal, do you talk your patients through kind of an ideal weight or kind of healthy lifestyle before they incur a knee surgery? Or what kind of prep would someone expect for that?
Well, I think if we're just going to talk like about ACL injuries, I think, we really found that, when you have an injury, it certainly depends on the severity, if there's other associated injuries. But if we just say like an isolated ACL injury, we don't just jump right into surgery. It's very important to really condition the knee. And what we really found is what we call preconditioning. And that's where you, make sure the knee has a good range of motion. The worst thing to do is operate on someone that has a stiff knee or that still has a lot of swelling, because that can make the recovery prolonged and actually more difficult. And so we look at how much motion we can get the knee before we go into surgery. We also look at starting to get some strengthening, starting to get the quadricep muscles firing again. And then afterwards, during the recovery, and then of course, proper nutrition and strengthening other parts are important. The therapists are good about, looking at a patient's, overall health and maybe working on core strengthening, all that stuff. We're starting to find that plays into it. It's not just, you can't just isolate the knee. It's got to be the whole body type of thing. And then certainly on the back end of that, after surgery or after recovery, I think it's extremely important to implement, when they do get back to whatever sport they want to get back to, a good preconditioning program, making sure that those things, because a lot of times when they get in, again, injuries there's some unpredictable. We can't always predict when we're getting injured, but a lot of times when we see these injuries, there are some things that we could have maybe improved upon before, that maybe might have prevented an injury happening.
Great. The next question is, how can I tell the difference between posterior tendon tightness and ligament issues?
Like posterior ligament tightness and Can you repeat the question again? Sorry.
Yeah, no worries. How can I tell the difference between posterior tendon tightness and ligament issues?
Okay. Um, I think I'm going to take this more maybe, and I might be inferring, but maybe posterior capsular tightening versus the ligament tightening. And the knee is surrounded by a whole capsule, and certainly when you get an injury, and a lot of times especially let's say like a meniscus injury or an ACL injury, the knee gets, you put your knee in a position of comfort, and typically it's a little bit of flexion. And so what happens is, if you keep that knee in that position and you don't, fully extend the knee, the posterior capsule can tighten. And then, again, this is what I'm referring. And so that can be a difficult thing to get back, that extension. Extension is the hardest thing to get back after any type of knee injury or any type of knee surgery. And that's just because of that posterior capsule, because again, the position of comfort for most people is to keep their knees slightly flexed. And then when that happens, that posterior capsule and even the muscles in the back of the knee can kind of contract. And so that can be a difficult thing to try to get out. And so, one of the first things that we really try to focus on after surgery is to get that extension. I mean, that's an important, that's not just with ACLs, that's with any type of knee surgery, whether it be total knees or whatever. Now it can be hard to get that prior to surgery, because sometimes if you have a ligament, like an ACL, rupture or a meniscus rupture or tear, that ligament or that meniscus can be displaced in a way that it won't allow you, it can be a mechanical block, and it won't allow you to extend that knee.
Great.
I hope that answers it.
I hope so too. I think you did a great job. And I think we're wrapping up on questions, but if anyone else has one, feel free to enter that in. Oh, you got some nice kudos. I didn't know if you wanted to just quickly touch on same day joint replacement, just who would qualify
Sure.
for that, and then what the benefits are as we wrap up.
Yeah, I mean, it's pretty amazing how just with total joints in general, how things have evolved. I mean, I remember when I was in residency down in San Francisco, I did my training with a very an excellent total joint surgeon. And I remember they'd have their joints come in, total joints come in 2 days prior to the surgery, and the residents would, make sure they get admitted. They would, go through a routine, they would have their surgery, and then they would be in the hospital for 5 to 7 days after the surgery. And what we're finding now is that really a lot of patients don't need that, and the majority of patients don't need that. We're starting to see more and more that a lot of things can be done at home, and patients actually recover better at home with the appropriate support, of course. And that means that, with the same day total knee, we'll do the surgery in the morning and they'll get a block, and that's the other thing that's been advanced is, these peripheral nerve blocks. So like an adductor canal block, they'll get a block so they don't even feel pain or not a significant amount of pain for the first 12 to 24 hours. And it allows them to get up and move around and get the knee moving. And so typically with the same day, they'll have the surgery done, they'll be in the recovery, therapy will come down and work with them. And if they meet their criteria of, they're going to be safe walking around with a walker or with some type of, assistance, and they have, of course, obviously support at home, then they'll be, and their pain's controlled, then they'll be able to, to go home that same day with close follow-up. Typically, home health and therapy will see them in that house the next day and then see the surgeon, a few days later. But the things that they've shown is the risk of complications actually has gone down. Certainly things like infections and DVTs and things like that, just because when you're at home, you certainly heal better. You're in a more familiar environment. And so I think it's not for everybody. Certainly people that have higher risk with comorbidities like, multiple medical issues, things like that, I think aren't, but young, healthy, or even older healthy people are. And the interesting thing, we've all had a dramatic change in things with COVID-19. I mean, we've seen some dramatic changes in all of our lives, not just, in medicine, but, one example is the Zoom. I mean, a year ago we'd be in person and then we'd have to worry about people coming out because it snowed, but now we can do this without having to worry about those things. But the one thing that we've been seeing is, we've been, really critically looking at our patients and saying, hey, do we need to keep them in the hospital? Try to keep them, let's see if we can safely keep them out of the hospital so there's less exposure to other things that can maybe cause harm. So I think as things continue to advance, and Medicare is certainly looking at these things, the majority of total joints will be done as an outpatient.
That's incredible. Thank you again, Dr. Swanson. I think that just wraps up all the Q&A for tonight. And like you said, this is a new platform for us, so I appreciate you coming on tonight and being here, especially given the snow. So I'll wrap this meeting up and just want to say thank you again. I hope you have a great evening.
Thank you. Appreciate it. Thanks for everybody. I don't know how to click out of here, so
I'll click us out.
Okay, thanks.
Have a good night.
All right.